St. John. Welcome to St. John, guys. Yan. First aid training. It's the first aid kit. Yan. Guys, nandito po tayo ngayon sa St. John First Aid Training. Ayan, New York Price. So, company po namin ang nagpapatraining sa amin. Obliged po kami lahat. Ayan si Chris. Woo!
Oh, wow.
Inside St. John room.
Are you okay? I feel a bit dizzy. Here, hang on to me. We're just gonna step.
Perform a scene survey. Find out what happened, the mechanism of injury, and the number of casualties. Check for hazards and remove them if possible. If you cannot remove the hazard, move yourself and the casualty to a safe place. Put on gloves if you have them.
Hey, can you call 911?
If the casualty is not responsive or if you are unsure, call 911. Open the airway using the head tilt, chin lift method. Place one hand on the forehead and 2 fingers of the other hand under the chin. Check for breathing by watching the chest for movement, listening for sounds of breathing, and feeling for their breath on your cheek. A breathing casualty has a pulse. Check the quality of their circulation by feeling the temperature and condition of their skin. If their skin is cool, sweaty, and lacking color, they need immediate help. Check from head to toes quickly for any severe bleeding or other injuries. This is called a rapid body survey. Work quickly but carefully to check their head, arms, chest, back, and legs for any bleeding. Remember to check your gloves frequently for blood. If the casualty is breathing, has no signs of bleeding, but remains unresponsive, roll them into the recovery position. This position keeps their airway open and allows you to monitor them while you wait for medical help to arrive. To place someone in the recovery position, kneel beside them and bring the arm closest to you straight out from the body. Bring the forearm across the chest with a hand up to the shoulder. Bend the far leg at the knee. Start rolling them toward you by pulling on the bent knee. Guide them over onto their side with their shoulder. Adjust the legs and hand to keep them from rolling onto their front. Cover them with a blanket and record what you have found and what you have done. Protect their valuables, monitor their ABCs, and wait for medical help to arrive. Give an oral report.
Hey, Lisa?
A casualty who was found lying on their stomach may need to be moved for a primary survey to be performed. Perform a scene survey. Check for hazards and call for help. Check for responsiveness.
Hey, Lisa, can you hear me?
Begin the primary survey in the position found. If normal breathing is not detected or you cannot properly assess the casualty, position the arm closest to you with the arm above the casualty's head. Cross the ankles, support the head and neck, and pull the casualty towards you by the hip. Once the casualty is on their back, continue with the primary survey.
Shock is a circulation problem caused when the body's tissues don't get enough oxygenated blood. Any illness or injury will cause shock. Shock is progressive. It gets worse over time if not managed properly. Shock is life-threatening because the brain and other organs cannot function properly without a constant supply of oxygenated blood. As shock progresses, it leads to unconsciousness and even death. You will always give first aid for shock when dealing with an illness or injury. In order to get adequate oxygen to the body's tissues, especially the brain, a person needs a supply of oxygenated blood, vessels to transport that blood, and an effective pump to move the blood through those vessels. Shock is caused when the effective circulation of the oxygenated blood is impeded.
That can happen if the heart's ability to pump is compromised, a heart attack for example, if there is no oxygen in the blood, when the casualty chokes for instance, if the vessels dilate as can happen during a severe allergic reaction, or if the blood volume is lost to an external wound or swelling. When a casualty goes into shock, their body is compensating for the problem and will make sure the vital organs get the blood first, since skin and muscle can go without adequate oxygen for a longer period of time. The peripheral blood vessels constrict to drive blood out of the surface of the body and into the core. This makes the casualty's skin look odd. The casualty can have pale, grayish skin. It may be blue tinged at the lips, tongue, earlobes, and extremities from the lack of oxygen in those tissues. The skin will feel cool to the touch, and the sweat glands will relax, making the casualty clammy with sweat. The casualty will try to get more oxygen into the vital organs to make up the shortfall, so their breathing will get faster and shallower, the heart rate will increase. As shock progresses, the lack of blood in the muscles makes the casualty fatigued and weak. Blood flow to the stomach and intestines is curtailed, causing digestion to stop. Anything in the stomach is unwanted now, so the casualty may complain of nausea or may vomit. If shock continues, the brain finally starts feeling the lack of oxygen. The casualty will become confused, perhaps combative, and eventually will lose consciousness. First aid for shock begins with performing first aid for the cause. Clear the airway, make it as easy as possible to breathe, stop the bleeding, or assist with the casualty's medication. Do something for the underlying cause. Cover the casualty to keep them warm. If they are conscious, position them on their back to make it easy for blood to reach the brain, or help them into the semi-sitting position if it helps their breathing. An unconscious casualty is in danger from a blocked airway. Use the recovery position to keep their airway clear. Reassure the casualty to keep them calm. Moisten the lips if the casualty complains of thirst. Don't give anything to eat or drink. Loosen tight clothing. Fainting is a loss of consciousness that lasts a very short time, no more than a few minutes. It is caused by a temporary shortage of oxygenated blood to the brain. Some common reasons people faint are fear or anxiety, severe pain, injury or illness, long periods of standing or sitting, lack of fresh air, fatigue, or hunger. A person who feels faint often looks like a casualty in shock. They look pale and are sweating. They may complain of feeling nauseous, dizzy, or unsteady. First aid for someone feeling faint is to restore adequate circulation to the brain. Place the casualty flat on their back if possible, or at least sit them down. Ensure a supply of fresh air, loosen tight clothing at the neck, chest, and waist, and stay with the casualty until fully recovered. They should feel better quickly. If the casualty has fainted, they are unconscious, which means a breathing emergency, because in an unconscious person, the tongue may fall to the back of the throat and block the airway, or saliva and other fluids can pool at the back of the throat. Perform a scene survey and a primary survey. Is this indeed just a faint? Have they injured themselves falling down? If it's just a faint, they should regain consciousness rapidly. Perform ongoing care until they are fully recovered.
Oh my goodness.
Start with a scene survey. What happened? Are there still hazards to deal with? What is the mechanism of injury? Make the area safe for yourself and others. Put gloves on if you have them. Stabilize the head and neck and assess responsiveness. Call for medical aid.
Hi, this is for a car accident.
Assess for life-threatening conditions by performing a primary survey in the position found. Check for normal breathing for at least 5 seconds, but no more than 10 seconds. Instruct a bystander how to steady and support the casualty's head and neck. The first aider is now free to assess circulation. Take note of the skin condition and temperature. Perform a rapid body survey to check for any hidden injuries. If there are no injuries to manage, the first aider should continue to give ongoing casualty care until medical help arrives. Because spinal injuries are suspected, the casualty is kept in the position found, head stabilized. Reassess circulation and cover the casualty to help manage shock. Check skin condition once again and compare to the first circulation check. Record your findings and give an oral report to medical aid on the incident, the casualty's condition, and the first aid given. Neck and spine injuries should not be moved, if at all possible.
Do you have anything in your mouth right now?
If the airway is in danger from blood or vomiting, for example, the first aider should be prepared to protect the airway by rolling the casualty onto their side using the log roll maneuver. Work together to prevent bending or twisting of the spine. Position the arm closest to you straight up over the head. Position the arm furthest from you on the casualty's chest. Cross the far leg over the near leg at the ankle. Reach behind the casualty's shoulder. At the same time, roll the casualty towards you by pulling the clothing at the hip as one unit.
Ready? On my count. On 1. 3, 2, 1.
Clear the mouth of obstructions. Adjust the position of the arms and legs so the casualty is in a stable position. Place the far arm at 90 degrees to the casualty with a hand protecting the face resting on a lower arm. Consider the position of the first aider at the head. They may need help to reposition themselves.
Asthma is a respiratory illness where the airways react to a trigger by constricting, swelling, and producing thick mucus. This may cause serious difficulty in expelling air from the lungs. Perform a scene survey and make sure everyone is safe. Identify yourself and get consent. Ask what happened to learn the history of the incident. A casualty with a history of asthma will tell you what they need you to do. They may need your help to retrieve their meter dose inhaler. Perform a primary survey. A severe asthma attack may cause coughing and wheezing, obvious respiratory distress. The casualty may adopt the tripod position, sitting upright and leaning forward to make it easier to breathe. They may be anxious and complain of tightness in the chest. Lack of oxygen may make their skin bluish at the lips and extremities. As soon as you identify an asthmatic emergency, call for medical aid and retrieve their medication. If the casualty cannot use their inhaler, the first aider will have to help. Shake the inhaler for several seconds, remove the protective cap, then hold the inhaler in front of the mouth, or in the mouth if it's easier, and press on the canister to deliver a dose as they breathe in. The casualty should hold their breath for 10 seconds. In a severe asthma attack, it will be difficult to coordinate the inhaler with the rapid breathing of the casualty, so the use of a spacer is recommended. This will hold the aerosol medication so they can inhale it over several breaths. Place the casualty in a comfortable position, usually sitting upright and leaning forward, and continue ongoing care until medical help arrives. Be prepared to assist with a second dose of medication if the symptoms reoccur.
That one looks tricky.
Diabetes is a group of metabolic diseases in which the casualty's blood sugar levels vary over time. This is due to either the pancreas not producing enough insulin or the cells of the body not responding properly to the insulin produced. As a result, sugar builds up in the blood and the cells don't get the energy they need. There are 2 diabetic emergencies which may require first aid: hypoglycemia, low blood sugar, and hyperglycemia, high blood sugar. It is important for first aiders to recognize the casualty's condition as an emergency. The aim of first aid in a diabetic emergency is to keep the casualty's condition from getting worse while you get medical help. Hypoglycemia has a rapid onset and can happen if the casualty takes too much insulin, misses a meal, vomits up a meal, or exercises more than expected. They present with rapid and shallow breathing, pale, cold, and clammy skin, and feeling faint and losing consciousness. They are often irritable and aggressive. Hyperglycemia has a very slow onset and happens when the casualty does not take enough insulin, eats more than usual, or exercises less than expected. This casualty presents with rapid, deep breathing, flushed, dry, and warm skin, and growing drowsiness. Their breath often smells like nail polish remover. Perform a scene survey. Identify yourself and get consent. Ask what happened to learn the history of the incident. If the casualty can tell you what they need, help them take what is needed. Usually, this is sugar. If the casualty is confused about what is needed, give them something sweet to eat or drink. Sugar will help hypoglycemia and will not make the hyperglycemic casualty any worse. Make sure there is no danger of them choking. Medical aid is usually required if the situation requires first aid. If the casualty loses consciousness, perform ongoing care. Protect the airway with the recovery position and monitor the ABCs until help arrives. Seizures are caused by abnormal electrical activity in the brain. A common cause of seizures is epilepsy, a chronic condition with no immediate underlying cause, but seizures may also be caused by injuries to the brain, a stroke, drug overdose, or high fever. In a partial seizure, only part of the brain is affected. The casualty may experience a tingling or twitching in one area of the body. In a generalized seizure, the whole brain is affected. The casualty may be able to give some warning that a seizure will occur. They may experience an aura, a sensation which precedes their seizures. A casualty with a history of seizures may tell you what they need you to do. A typical generalized seizure has two phases. The tonic phase involves a sudden loss of consciousness, causing the casualty to fall. Lay the casualty down in anticipation of the loss of consciousness. The casualty's body may become rigid, and the face and neck may turn bluish. In the clonic phase, convulsions occur, sometimes violent convulsions. Breathing is noisy, frothy saliva may appear around the mouth, and the teeth may grind. This seldom lasts more than a few minutes. Perform a scene survey and make the area safe. First aid for a seizure aims to protect the casualty from injury during convulsions and to keep the airway open while the casualty is unconscious. Do not try to restrain the casualty. Protect the airway, but never place anything in the casualty's mouth. After the convulsions stop, the casualty will slowly regain consciousness. In this post-ictal state, they may be confused and may feel exhausted from the convulsions. Give ongoing care. Take a vital sign record and perform a head-to-toe examination to determine if there have been any injuries from the convulsions. The first aider should consider calling for medical aid if there have been injuries, if the casualty remains unconscious for more than 5 minutes, if there is a second seizure within a few minutes, or if this is the casualty's first seizure. A rapid rise in core body temperature, usually caused by a fever, can cause convulsions in infants and children. A fever emergency is when the temperature, taken in the armpit, is 38 degrees Celsius, 100.5 degrees Fahrenheit or higher for an infant, 40 degrees Celsius, 104 degrees Fahrenheit or higher for a child. A fever emergency requires medical attention. The first aider should contact the infant's doctor and follow the advice given. First aid for a fever emergency involves cooling the casualty by sponging with lukewarm water and the appropriate dosage of acetaminophen to lower the body temperature. If convulsions occur, the first aider should handle the casualty as for any seizure casualty, protect from harm, and maintain the casualty's airway. Severe allergic reactions, anaphylaxis, can quickly produce respiratory difficulty and low blood pressure, both of which are potentially fatal. A casualty with severe allergies will have a prescription drug called epinephrine available in an auto-injector. The first aider must recognize the anaphylactic emergency and assist with the medication quickly. Perform a scene survey and make sure everyone is safe. Identify yourself and get consent. Ask what happened to learn the history of the incident. A casualty with a history of anaphylaxis will tell you what to do. They may need your help to retrieve their auto-injector. Perform a primary survey. The casualty who cannot tell you what is happening will usually show 2 or more of the signs and symptoms of an anaphylactic emergency. The casualty may be having trouble breathing if there is swelling of the airway. You may see the swelling externally at the lips and tongue and the face in general. The skin may show hives, red-rimmed raised bumps on the skin, which are very itchy. The casualty may complain of nausea and may vomit. If their blood pressure is dropping, they may experience lightheadedness and a feeling of doom. As soon as you identify an anaphylactic emergency, retrieve an auto-injector and call for medical aid. If the casualty cannot use their auto-injector, the first aider will have to do it for them. Follow the instructions or voice prompts and press the orange or black end of the auto-injector firmly into the fleshy outside of the mid-thigh. Hold firmly for several seconds for the entire dose to be delivered. Place the casualty in a comfortable position, lying down if possible, and continue ongoing care until medical help arrives. Be prepared to assist with a second dose of epinephrine if the symptoms reoccur. The contents of the first aid kit in your workplace are determined by the occupational health and safety regulations of your province or by the Federal Labor Code. A personal first aid kit is designed to meet your needs at home or in the outdoors. To deal with severe bleeding, a first aid kit will contain dressing and bandages. A dressing is a protective covering put on a wound to help control bleeding, absorb blood from the wound, and prevent further contamination. You may have access to hemostatic dressings, specialized dressings that contain materials designed to enhance blood clotting in large wounds. A bandage is any material that is used to maintain pressure over a dressing on a wound, support a limb or joint, or immobilize parts of the body with a splint. A triangular bandage may be used as a whole cloth, opened to its fullest extent as a sling or to hold a large dressing in place, as a broad bandage to hold splints in place or to apply pressure evenly over a large area, as a narrow bandage to secure dressings or splints. When using a triangular bandage, the reef knot is the best knot to use because it lies flat, making it more comfortable than other knots. It doesn't slip, and it is easy to untie should it have to be removed or readjusted. To tie a reef knot, take one end of a bandage in each hand. Lay the end from the right hand over the one from the left hand and pass it under to form a half knot. This will transfer the ends from one hand to the other. The end now in the left hand should be laid over the one from the right and passed under to form another half knot. The finished knot looks like two intertwined loops. Tighten by pulling one loop against the other or by pulling only on the ends. To untie the reef knot, pull one end against the loop to deform the knot, then slide it off the other end. Roller bandages are made of gauze-like material or heavier crepe material packaged as a roll. They may already be attached to a wound dressing. Put on a roller bandage in a simple spiral. Always start at the narrow part of the limb. Anchor the bandage as follows. Place the end of the bandage on a diagonal at the starting point. Wrap the bandage around the injured part so the corner of the bandage end is left out. Fold this corner of the bandage over and wrap the bandage around again to cover the corner. Continue wrapping the bandage, overlapping each turn by 1/4 to 1/3 of the bandage's width. Make full width overlaps with the final 2 or 3 turns and secure with a safety pin, adhesive tape, or by cutting and tying the bandage as shown.
Perform a scene survey and make sure everyone is safe. Ask what happened to learn the history of the incident. Identify yourself as a first aider and get consent. Perform a primary survey. Airway and breathing are easy to check by asking questions. Expose obvious bleeding and assess the injury. Severe bleeding may be from a large wound with lots of venous blood flow or a wound that involves an artery causing blood to spurt out of the wound with every heartbeat. Tell the casualty to apply direct pressure over the wound. Make sure 911 has been called as soon as you assess this is a life-threatening injury. As soon as possible, replace the casualty's hand with a pad of dressings and continue applying direct pressure. Add dressings as required. Once bleeding is controlled, check for shock by checking the skin condition and temperature, and do a rapid body survey to ensure there are no other serious injuries. As soon as possible, replace the hand pressure over the wound with a bandage. First, check for impaired circulation below the injury. Compare the temperature and color of the fingers on the injured side with the uninjured side. Prepared wound dressings may have a roller bandage already attached. Wrap the bandage over the entire dressing. Once the bandaging is complete, place the injured arm on the casualty's chest and check circulation below the injury again. Give ongoing casualty care until you can hand over to medical help. Give first aid for shock. Upper limb amputations account for the majority of traumatic amputations. Crushing and cutting forces from operating machinery and motor vehicles are the most common mechanisms of injury. Perform a scene survey and make sure everyone is safe. Ask what happened to learn the history of the incident. Expose obvious bleeding and assess the injury. Tell the casualty to apply direct pressure over the wound. Make them comfortable and make sure 911 has been called. As soon as possible, replace the casualty's hand with a pad of dressings and continue applying direct pressure over the wound to control the bleeding. Add dressings as required. Check for shock by checking the skin condition and temperature, and do a rapid body survey to ensure there are no other serious injuries. As soon as possible, replace the hand pressure over the wound with a bandage. Bandage the dressings in place. Once the bandaging is complete, place the injured arm on the casualty's chest. It's important to find any amputated parts. There is always a possibility they can be surgically reattached. As best you can, you need to keep amputated parts cool and clean. Wrap them up with moistened sterile dressings and place them in a plastic bag. Place that in another bag with some ice if available. Most importantly, send the amputated parts with the casualty to medical care. If an ambulance is coming, give ongoing casualty care until you can hand over to medical help. If you must move a casualty, consider using a St. John ambulance tubular sling to support the injury. Partial amputation should be repositioned and dressings applied once the bleeding is controlled. Carefully move the partially amputated finger back to its normal position. Wrap the dressing around the open wound and have the casualty apply pressure. Using a rolled bandage, start by wrapping the dressing to maintain pressure. Continue wrapping, using the bandage to splint the partially amputated finger to the fingers on either side. If the partially amputated part is not a finger, use a padded splint to support the limb. Check circulation after bandaging. A partially amputated part is expected to have poor circulation.
The eye is a very sensitive organ and can be injured very easily. For this reason, extra care must be taken to protect the eyes from hazards. When an eye is injured, proper first aid given right away may prevent partial or complete loss of eyesight. A particle of sand, grit, or even a loose eyelash on the eyeball or under the eyelid can cause discomfort and inflammation of the tissue around the eye. The casualty's own tears may not flush out the offending particle. If a loose particle, such as dust or an eyelash, is suspected, and the particle is not sharp, the first aider should begin by asking the casualty where he feels the particle is located. If it feels like the particle is under the upper lid, instruct the casualty to grasp the upper eyelashes and pull the lid straight out and then down over the lower eyelashes to try to sweep the particle away. If the particle is still in the eye, try flushing it out using clean running water from a tap, an eye cup, or eye wash bottle. If the above methods have not been successful, you will need to examine the surface of the eye and under the lids. To examine someone's eye, you should begin by washing your hands and putting on gloves. Seat the casualty facing a good light and steady the head. With the eyes wide open and the eyelids well separated, instruct the casualty to look to the left and hold this position while you examine the other corner of the eye. A pen light will make it easier to locate the particle. When the light is directed across the eye, it will cause a shadow to appear if the particle is in the path of the light, making it easier to see. After examining the corners of the eye, you will need to examine under the upper and lower lids. To examine under the lower lid, gently pull down on the lower lid and ask the casualty to look up. Use your pen light to check inside the lid. To examine under the upper lid, gently pull up on the lashes and ask the casualty to look down. Use your pen light to check under the lid. If you locate the particle, remove it gently using the moist corner of a facial tissue, clean cloth, or cotton-tipped applicator. Do not try to remove a particle that is stuck to the eye or is located on the colored part of the eye. If the particle in the eye is not coming out or is on the colored part of the eye, medical aid is required. You should close the casualty's eye and cover it with an eye or gauze pad. Extend the covering to the forehead and cheek to avoid pressure on the eye. Secure lightly in position with a bandage or adhesive strips. Make sure there is no pressure on the eyeball. Give ongoing casualty care and get medical help. Wounds to the eyelid and soft tissue around the eye are serious because there may be injury to the eyeball. If the eyeball is not damaged, vision should not be impaired once the wounds have healed. A dressing on the area will usually control bleeding. Never apply pressure to the eyeball. This may force fluid out of the eyeball and cause permanent damage to the eye. First aid for an embedded object in or near the eyeball is to leave the object where it is, stop the bleeding, and get medical help. Prevent the embedded object from moving, since movement could cause further damage to the eyeball. Lay the casualty down and, if available, have a bystander support the head to reduce movement. Place dressings, preferably sterile, around the embedded object. Place padding or dressings around the object in a log cabin fashion to stabilize the object. Make sure there is no pressure on the eyeball. Arrange transportation of the casualty on a stretcher to medical help as soon as possible. When the eyeball has been pushed out of its socket, it is called extruded. Do not try to put the eye back into position. Lay the casualty down and, if available, have a bystander support the head to reduce movement. Wash your hands and put on gloves. Gently cover the eyeball and socket with a moist dressing. Hold this in place with tape and more dressings. Place the casualty face up on a stretcher with the head immobilized for transportation to medical help. Give ongoing casualty care until handover. The eyes are very sensitive to chemical burns. If the chemical is a dry powder, brush away whatever is on the skin. Use a cloth to brush the powder away from the face. Do not use your bare hands. Flush the injured eye with cool water. Since pain may make it hard for the casualty to keep the eye open, gently open the eye with your fingers. Flush the eye for at least 15 minutes. If the casualty is wearing contact lenses, don't waste time trying to remove them. Flush the eyes for 15 minutes. This may wash the lenses out. If not, have the casualty remove them. Cover the injured eye with dressings. If both eyes are injured, cover the more seriously injured eye. Only cover both eyes if the casualty is more comfortable that way. Get medical help right away and give ongoing casualty care. Burns to the eyes may be caused by intense light, such as direct or reflected sunlight and arc welder's flash. Snow blindness is a common injury of this kind. As with a sunburn, the casualty may not feel the tissue damage happening, but will develop symptoms several hours after exposure. Signs and symptoms include sensitivity to light, pain, and a gritty feeling in the eyes. Cover the eyes to cool them and keep the light out. The casualty will be temporarily blinded, so reassure them often and explain what you are doing. Give ongoing casualty care and get medical help. Burns are wounds caused by heat, radiation, electricity, or chemicals. They are a leading cause of injury in the home, especially for young children and elderly people, and at these ages, burn injuries are very serious. The skin protects the body from bacteria, helps regulate body temperature, and retains fluid in the body. Damaged skin can't perform these vital tasks. A burn is described as superficial, where the top layer is damaged, making it red and painful. A partial thickness burn, where both layers of skin are damaged and blisters and swelling can happen. And a full thickness burn, where the burn extends through the skin into the fat and muscle beneath. It's not just the depth of a burn that makes it serious, though. The size of the burn and the location is critical as well. A superficial burn over most of the body is as likely to produce serious shock as a small, full-thickness burn on a limb. You should seek medical attention for any burn to someone under 2 or elderly. These age groups are at higher risk of shock. That produces breathing problems. Inhalation injuries can damage the airway. that happens at a joint, the knee or the elbow for example, these will not heal well. Any electrical or chemical burn should be seen by medical aid. There may be complications. Heat burns, also called thermal burns, are the most familiar kind of burns. Common heat sources include open flames and hot objects. A scald is a heat burn caused by hot liquid or steam. Heat burns can also be caused by friction. First aid for heat burns involves cooling the burn right away. Immerse it in cool water if possible, pour cool water on the area, or cover it with a clean, wet cloth. Cool the burn until the pain has lessened. This will reduce the temperature of the burned area and reduce tissue damage, swelling, blistering, and relieve the pain. Be careful cooling large area burns. You may cause hypothermia. Loosen or remove anything on the burned area that is tight. This means jewelry and tight clothing. Do this as soon as you can, before the injury swells. Don't remove anything that is stuck onto the burn. When the pain has lessened, loosely cover the burn with a clean, lint-free dressing. If the area is large, use a sheet. Secure the dressing with tape, making sure there is no tape on the burned area. Give ongoing casualty care, including arranging for medical help, first aid for shock, and monitoring the casualty. Chemical burns are often serious because the chemicals continue to burn as long as they remain on the skin. Examples of industrial chemicals that can burn include acids, alkalis, and phosphorus. Common chemicals kept in the home that can burn include paint stripper, oven cleaner, drain cleaner, and rust remover. First aid for chemical burns means removing the chemical from the body by flushing the area with large amounts of cool water. Don't delay flushing to remove clothing. If the chemical is a dry powder, quickly brush off any loose chemical with a cloth before flushing. Continue flushing the area with water for 15 to 20 minutes. When the area has been flushed, loosely cover the burn with a clean, lint-free, preferably sterile dressing. Give ongoing casualty care, including arranging for medical help. If the casualty complains that the burning sensation increases, flush the area again for at least 10 minutes. Electrical burns result from contact with an electric current. Although it is heat that causes these burns, electrical burns are considered separately because of the complications caused by the electricity. An electrical current going through the body can cause the heart to stop. Also, an electric shock can violently throw the casualty. Head and spinal injuries, fractures or dislocations may be present. There is also the danger of electrical injury to the first aider. Electrical burns can be either flash burns or contact burns. A flash burn results when electricity arcs from the electric source to the casualty, producing intense use when exposed to temperatures below zero. It is a progressive injury with 2 stages: superficial frostbite and deep frostbite. In superficial frostbite, the full thickness of the skin is frozen, making the skin look white and waxy. The skin may feel firm to the touch, but the tissues underneath are soft. The casualty will feel pain at first, but the area may become numb. In deep frostbite, the skin and the tissues underneath are frozen, sometimes right to the bone. The area feels cold and hard, and there is no feeling. Fingers and toes are the most commonly frostbitten areas, but noses, cheeks, and ears, or any exposed skin can freeze. Superficial frostbite can be rewarmed by getting the casualty out of the cold and using body heat to warm the affected part. Cover frostbitten toes, ears, etc. with warm hands. Warm up frostbitten fingers by placing them in a warm area of the body, like the armpit, abdomen, or groin. The casualty may experience pain as the parts rewarm. Take measures to prevent these areas from freezing again. Either stop the activity or dress more appropriately. As a heart attack, it is often caused by a narrowed artery in the heart, which does not allow adequate circulation to the heart muscle. If the narrowing is temporary, the pain or discomfort is called angina. It can be relieved with rest and medication, usually nitroglycerin. If the lack of circulation is profound, the heart muscle can die due to a lack of oxygen. The casualty suffering angina or a heart attack will show signs of shock. They look pale or with ashen skin, and there may be blue-tinged earlobes, lips, and fingertips because blood is being redirected to the vital organs. They feel cold and clammy as there is no blood in the skin and the sweat glands have relaxed. They may be breathing poorly, rapid, and shallow.
To restore a normal heart rhythm. Perform a scene survey. Take charge of the situation. Call out to attract bystanders to assist you. What happened? Are there still hazards to deal with? What is the mechanism of injury? Are there suspected injuries? Assess for responsiveness and call for medical aid and an AED if available. Assess for life-threatening conditions by performing a primary survey. Open the airway using the head tilt, chin lift. If the casualty is not breathing or has abnormal, irregular, or gasping breaths, start CPR right away. Kneel facing the casualty so that the hands can be placed mid-chest. Place the heel of one hand midline on the breastbone and place the other hand on top. Compress the chest at least 5 centimeters in a smooth, rhythmic pace at a rate of 100 to 120 compressions per minute. Be sure to allow the chest to fully recoil from the compression. Give 2 ventilations with just enough force to make the chest rise. Take care not to overventilate and force air into the casualty's stomach. Continue chest compressions. CPR is continued until an AED can be applied. The casualty begins breathing again, medical help or another rescuer takes over, or the first aider is too tired to continue.
So what we are...
Children typically have healthy hearts, but respiratory emergencies like suffocation or choking can produce respiratory and cardiac arrest. Immediate first aid is critical in resuscitating the child if the casualty is unresponsive.
Sorry. Hindi ko kaya. Baka magkasakit tayo dito.
Call 911 and ask if an AED is available. Once help is on the way, assess for life-threatening conditions by performing a primary survey. Open the airway using the head tilt, chin lift. If the casualty is not breathing or has abnormal, irregular gasping breaths, start CPR right away. Kneel facing the casualty so that the hands can be placed mid-chest. Place the heel of one hand midline on the breastbone. You can place the other hand on top of the fist, or on a small child, use the one hand only, with arms straight, elbows locked, and shoulders positioned directly above the heel of the hands. Give 30 compressions straight down on the breastbone. Compress the chest at least 1/3 depth of the chest, or about 5 centimeters, in a smooth, rhythmic pace at a rate of 100 to 120 compressions per minute. Be sure to allow the chest to fully recoil from the compression. Give 2 ventilations with just enough force to make the chest rise. Take care not to overventilate and force air into the casualty's stomach. CPR is continued until an AED can be applied, the casualty begins breathing again, medical help or another rescuer takes over, or the first aider is too tired to continue. As soon as the AED arrives, turn it on. Some models will turn on when the case is open. The rescuers now follow the voice prompts. If the AED has child or pediatric pads, use them. Otherwise, use the adult pads. Peel away protective plastic and attach electrode pads according to the images on the child pads. If using adult pads, place one on the front and one on the back of the child. Stand back and make sure no one is touching the casualty. If a shock is advised, you may need to press the shock button. Many new AEDs will automatically deliver a shock. Make sure no one is touching the casualty until the AED says it is safe to do so. Follow the voice prompts and continue CPR.
Many of the chest compressions will deteriorate. Second, by sharing the task of compressing the chest, 2 rescuer CPR allows for a team to perform effective chest compressions for a longer period of time. Finally, 2 rescuer CPR minimizes the time the compressions are interrupted for ventilations to be given and allows the rescuers to give feedback and support each other during a stressful episode. If a 2 rescuer team arrives at the same time, the first rescuer will send a bystander to call 911 and begin a primary survey, while the second rescuer prepares to deliver chest compressions. The second rescuer will deliver 30 chest compressions, counting out loud. After 30 compressions, the first rescuer will deliver 2 breaths. If there is no bystander, the second rescuer will go to call 911. When they return, they will take over at the direction of the first rescuer, usually starting with the compressions, since the second rescuer is fresh. Together, they will continue to deliver 30 compressions at a rate of 100 to 120 compressions per minute and a depth of at least 5 centimeters or 2 inches, followed by 2 breaths. After 5 cycles or roughly 2 minutes, the rescuer should change places after the breaths have been delivered to keep the compressor fresh. CPR should continue until an AED can be applied, the casualty begins breathing again, medical help or another team takes over, or the team is too tired to continue. As soon as the AED arrives, turn it on. With some models, just opening the case will turn it on. The rescuers now follow the voice prompts.
Apply pad to patient's bare chest. Plug in pads connector next to flashing light.
Bare the chest. Shave the chest if necessary. Dry the chest if necessary. Peel away protective plastic and attach electrode pads according to the manufacturer's directions. Stand back and make sure no one is touching the casualty.
Analyzing heart rhythm.
If the AED detects a shockable arrhythmia, it will prompt for a shock. Many newer AEDs are fully automatic and will deliver the shock if needed.
Shock advised. Charging.
I'm clear, you're clear, everybody's clear.
Deliver shock
Filipino.
now. Press the orange button now.
Close it.
Shock delivered.
If the AED has a shock button, the machine will prompt the rescuer to press the shock button. Continue to follow the voice prompts until the casualty begins to breathe on their own, or until medical aid arrives.
May cause brain damage. A condition which looks quite similar to a stroke is called a transient ischemic attack, or TIA. It has the same signs and symptoms as a stroke, but usually a TIA only lasts from a few minutes to several hours, but leaves no permanent brain damage. Advise anyone who has a TIA to get medical help immediately. Remember FAST as a way to check for the signs of a stroke and to get immediate help. Facial droop. One side of the face doesn't move as well as the other side. Arm drift. Have the casualty hold both arms out. One arm may not move or drifts down compared to the other arm. Speech. The casualty slurs words, uses the incorrect words, or is not able to speak. Time. Get immediate medical help. The earlier a stroke is treated, the better the outcome. Note the time the symptoms started. The first aid is the same for both stroke and TIA. Place the casualty at rest in the most comfortable position, usually semi-sitting.
Airway obstruction will be able to speak, cough forcefully, and breathe.
Are you okay?
If the casualty stops coughing, cannot speak, or isn't breathing, the first aider should act immediately. Give 5 back blows.
1,
Support
2,
the
3,
casualty's
4,
upper body,
5.
lean them forward, and
1,
deliver up
2,
to 5
3,
sharp
4,
blows in
5.
rapid succession between the shoulder blades, using the heel of your
1,
hand.
2,
If the
3,
casualty
4,
still cannot
5.
cough, speak, or breathe, give 5 abdominal thrusts. Place your fist midline against the abdomen. Grasp the fist with the other hand
Ganyan
and
lang pala
thrust inward and upward forcefully. The first aider should continue with back blows and abdominal thrusts until the airway is cleared or the casualty loses consciousness. One or the other will happen very quickly, so you must be prepared.
Let's get it.
1 to 8 years of age. Choking happens when the casualty suffers from a sudden obstruction in their airway. This is a serious emergency, which can lead to unconsciousness in just seconds. A casualty with mild airway obstruction will be able to speak, cough forcefully, and breathe. Stand by and allow them to clear their own airway. If the casualty stops coughing, cannot speak, or isn't breathing, the first aider should act immediately. Come down to the child's level, give 5 back blows, support the casualty's upper body, lean them forward, and deliver up to 5 sharp blows in rapid succession between the shoulder blades using the heel of your hand. If the casualty still cannot cough, speak, or breathe, give 5 abdominal thrusts. Place your fist midline against the abdomen. Grasp the fist with the other hand and thrust inward and upward forcefully. The first aider should continue with back blows and abdominal thrusts until the airway is clear or the casualty loses consciousness. One or the other will happen very quickly, so you must be prepared. If the abdominal thrusts are successful in clearing the airway, a child must be seen by a medical professional to ensure there are no serious injuries to the abdomen.
Kneel facing the casualty so that the hands can be placed mid-chest. Place the heel of one hand mid-line on the breastbone. With arms straight, elbows locked, and shoulders positioned directly above the heel of the hands.
Can produce respiratory and cardiac arrest. If the casualty is unresponsive, this is a life-threatening medical emergency. Call for medical aid and an AED if available. Once help is on the way, assess for life-threatening conditions by performing a primary survey. Open the airway using the head tilt, chin lift, and check the mouth for anything loose. If the casualty is not breathing or has abnormal, irregular, gasping breaths, start CPR right away. Ensure the casualty is face up on a firm, flat surface. Then position 2 fingers on the breastbone below the nipple line. With 2 fingers, compress the chest 30 times. Compressions should be at least 1/3 of its depth, or about 4 centimeters, and delivered in a smooth, rhythmic pace at a rate of 100 to 120 compressions per minute. Be sure to allow the chest to fully recoil from the compression. Give 2 ventilations with just enough force to make the chest rise. Take care not to overventilate and force air into the casualty's stomach. CPR is continued until an AED can be applied. The casualty begins breathing again, medical help or another rescuer takes over, or the first aider is too tired to continue. Because CPR alone is more effective at resuscitating an infant, it is recommended that CPR be performed for at least 2 minutes before an AED is used. If the AED is equipped with infant pads, follow the images on the pads. If the AED only has adult-size pads, place 1 pad on the front of the infant and 1 on the back. Follow the prompts of the AED, making sure everyone is clear of the infant while the AED analyzes and/or shocks.
Analyzing heart rhythm. Shock advised. Charging.
I'm clear, you're clear, everybody's clear.
Deliver shock now. Press the orange button now.
On 3, 1, 2, 3. Shock delivered. 1, 2, 3.
If the shock does not result in the infant breathing, or if no shock is advised, resume CPR. Fully and breathe. Stand by and allow them to clear their own airway. If the casualty's face becomes blue, coughing becomes weak with high-pitched, noisy breathing, or the infant is unable to cry, cough, or breathe, give 5 back blows while you support the head. Place the infant face down over your forearm and support the head and neck by firmly holding the jaw with your hand. Give back blows between the shoulder blades with the heel of the hand. Position the infant between hands and forearms and turn her over. Position 2 fingers just below the nipple line and give 5 thrusts. Repeat back blows and chest thrusts until the airway is cleared or the infant becomes unconscious. The infant should be seen by a doctor in case of any injury from chest thrusts or back blows. If first aid does not clear the obstruction quickly, the choking infant will lose consciousness. When the infant becomes unresponsive, have someone call 911. Ensure the casualty is face up on a firm, flat surface. Then position 2 fingers on the breastbone below the nipple line. With 2 fingers, compress the chest 30 times. Compress at least 1/3 of the depth of the chest, or about 4 centimeters, in a smooth, rhythmic pace at a rate of 100 to 120 compressions per minute. Be sure to allow the chest to fully recoil from the compression. Look in the mouth to see if the obstruction has been dislodged. Remove it if you can see it. Give 2 ventilations with just enough force to make the chest rise. If the chest doesn't rise, reposition the airway and try again. You may have failed to open it properly the first time. If the chest still does not rise, repeat chest compressions and attempts to ventilate. Chest compressions and attempts to ventilate are continued until the casualty begins breathing again, medical help or another rescuer takes over, or the first aider is too tired to continue.
But Overall, he's really good at self-care, but the key point in here is with the different kind of workplace we have, just protect the eyes, right? Even to our, I think this is the season now, the ice, melting ice, right? When in that sun, peaking sun, it's just straightforward to